Tonight's webinar is by Shire, the leading global biotechnology company focused on serving people with rare diseases and other highly specialized conditions. Shire strives to develop best-in-class products across their core therapeutic areas, including hematology, immunology, neuroscience, ophthalmics, lysosoma, storage disorders, gastrointestinal, internal medicine, endocrine, hereditary angioedema, and oncology. Shire employees go to work every day with a shared mission to develop and deliver breakthrough therapies for the hundreds of millions of people in the world affected by rare disorders and other high-need conditions, and who lack effective therapies to live their lives to the fullest. Our speaker tonight is Dr. Nichols. Dr. Nichols received her Doctor of Optometry degree from the University of California at Berkeley, completed a residency in ocular disease at Omni Eye Specialists of Colorado, and earned her MPH in biostatistics and PhD in vision science at Ohio State University. In 2014, Dr. Nichols was named Dean of the University of Alabama at Birmingham School of Optometry. Prior to that appointment, Dr. Nichols was a professor at the University of Houston College of Optometry, where she co-founded and served as executive director for the Ocular Surface Institute, a translational research institute focused on bench-to-bedside research in ocular surface conditions. Earlier, Dr. Nichols was faculty at the Ohio State University College of Optometry. She currently serves as a medical advisor to the Sjogren's Syndrome Foundation, has been an executive board member for the Tear Film and Ocular Surface Society, and a founding member of Ocular Surface Society of Optometry. A leading expert in dry eye disease, Dr. Nichols is or has been on the editorial boards of the journals Optometry and Vision Science and the Ocular Surface, and is extensively published. Her research interests encompass meibomian gland dysfunction, dry eye and menopause, dry eye diagnostics and therapeutics, and tear proteomics and lipidomics. Welcome, Dr. Nichols.
Good evening, everyone, and thank you for that lovely introduction. I was wondering if we were going to be able to get to the presentation this evening. Well, thank you all for joining us from your homes, wherever you are at work, to learn a little bit about dry eye this evening. I've called this presentation Dry Eye for Everyone, Ask, Look, and Do Something. This has become my recent mantra, in that we've been working on dry eye for so many years, and yet it is really something that everyone can do. And with recent treatment advances and new diagnostics coming out on the market, it should become more simple for all of us to take care of our patients better. I've fortunately had the opportunity to work with a number of companies. And as full disclosure, I have worked with Shire. I worked with Shire when they were still Sarcode, or with the molecule when it was still under investigation with Sarcode before it was sold to Shire. And I also have, for a number of years, worked with Allergan. And those two companies have two products that are commercially available, and we'll talk about them tonight. I prepared this presentation myself with my own materials, and I want you to know it's based on my personal experience and the experiences I've had in clinical research and clinical care. I also have had the opportunity to work for a number of years with the ocular surface community, in particular through the Tear Film and Ocular Surface Society, where I've had a number of memberships. And through this work, I've been able to participate in a number of important ventures, which have resulted in important knowledge being shared with the community. Having said that, a lot of that information is at the level of being very scientific and perhaps some would say dull. And so I want to try tonight to translate some of that into clinical care. Often I hear, oh, why do you need to know about that guideline, or what does that guideline really mean to me in clinical practice? And hopefully this will provide you with some information or some background that you can then translate into clinical care. I do co-edit a online e-newsletter called Ocular Surface News. It comes out every 2 weeks. You can find it online. Feel free to sign up. I feel that the columnists do a really wonderful job at bringing you really salient, current information that's clinical as well as related to billing and coding, management of difficult cases, and even how-to for those who are just starting out in dry eye. I do want to focus, though, that tonight is really about learning to do it in the way that works for you. Dry eye isn't hard, but how you incorporate it into your practice can be difficult. It takes a village sometimes. You have to work with your staff and maybe even work with your colleagues. In some instances, you might have to refer for some diagnostics through a practitioner who might have something that you don't. But in general, you can do dry eye in a very simplistic way. The most important thing is to find out what's just right for you. What's just right for you right now might not be what's right for you in 5 years after you've seen more patients or decided you wanted to move into it being a specialty within your practice. So as you go through this lecture, but more importantly, as you start to see patients, figure out for yourself what's your Goldilocks principle, what's just right. Tonight we're going to talk about the TFOS DEWS II process and the current definition and classification scheme, recommendations that that group has made towards diagnosis and treatment. We're going to talk about MGD and learn about some new techniques and new therapeutics in terms of the management of dry eye and MGD. In addition, we'll spend some time comparing and contrasting in probably a brief way the Canadian consensus, and some of which of you on the call likely play the role, and compare that to the DEWS process. In the end, that is a relatively didactic approach, but if for those of you who are actively using that consensus guideline in Canada, this will give you a chance to see what the global consensus looks like in comparison. Again, we'll talk about the definition classification, go through some new diagnostic developments, and have some cases at the end. Cases are difficult when I can't be with you in person, and so I'll be talking at you for some of those, but hopefully there'll be some key points that are transmitted through that. Dry eye today is a really different place than it was in 1995 when I started with dry eye. I've heard from so many different companies through ad boards and other things that that optometrists really should own this disease. And indeed, when I did my residency in Denver, I saw a lot of dry eye patients. At that time, I kind of liked the retina, and so when I went on to start a PhD, I kind of was thinking that I might still be a back of the eye kind of person. But I ran across a paper while I was in my residency that was published, which is where the first dry definition first came to light in the literature, and that was in 1995 in a document called Clinical Trials, the NEI Industry Clinical Trials in Dry Eye. And through looking at that paper, I realized, well, I kind of want to do something for my PhD that optometrists could relate to. I wanted to pick a topic that optometry could deal with. And at the time, we didn't have some of the technology that we have relative to the back of the eye. And so I guess went to the light side or the dark side, however you want to define it, and ended up picking dry eye for my career. So I really do think that optometry should own this disease. It's hard in some ways to incorporate it into clinical practice, but certainly you all know that you have patients who talk about dryness of their eyes, irritation of their eyes, with or without contact lenses, and many of you may even think that it's moving into the younger generation with all the screen time that kids and us as well use day to day. But we haven't been in or understood dry eye for that long. Back in 1995, dry eye was defined, and that's really in the lifetime of a disease, not old. So I would say that dry eye and our understanding of dry eye is still relatively in the infancy stage. Although when you look back in the United States, Restasis was approved in 2003. That was a hallmark occurrence, and from that time forward, I think we focused on inflammation as a key component in dry eye because we now had a therapy that could address some of that. However, I would say that there was adoption by some individuals and non-adoption by others for a variety of different reasons. In many ways, the field wasn't ready and clinicians weren't ready to really embrace managing dry eye. Having said that, Restasis has become a billion-dollar drug, and so it really has been remarkable in terms of the uptick by optometry and ophthalmology alike. If you talk to the company, Allergan, you do find that optometry efforts and efforts to engage and introduce optometry to dry eye have really paid off, and optometrists have really embraced dry eye as part of their practice. In 2016 in the United States, Xiidra, lifitegrast, was approved. Oops, that should have an E in there, sorry about that. And it definitely has been, I guess, an eye-opener. Certainly they went to market with an approach that was to blanket the scene with information about dry eye from a non-branded approach, and Jennifer Aniston was the spokesperson at first. That gained a whole lot of attention, and really I think in some ways Jennifer Aniston did more for dry eye in her little TV spot than many of us that have been slaving away in the research trenches for years have done, in that she kind of gave a name to a condition and increased awareness and started the conversation. All right, so I like to ask this question when I start a dry eye lecture. How familiar are you with the current definition and classification of dry eye as detailed in the 2017 DEWS II report? Have you heard of it? Have you tried any of it? Do you think that it's the brick that you put under your pillow so that you can sleep at night? Go ahead and answer yes or no. And when we hit a key number of you that have answered, then we will see the result. Often when I'm at meetings, I ask this question, and very often I have an audience that isn't aware of what the definition really does say, and that's okay. That's often why I'm there, is to help that out and help people to understand the current definition. All right, let's see. Okay, so here our answers popped up. It's about 50-50. So some of you know and some of you don't know. Well, we're going to go over that in a moment here. And hopefully at the end you can say, yes, you do know. Let's see if I can get it to go. Yeah, there we go. All right, well, back in 1995 when I first started in dry, there was the first ever definition. And as you can see, I'm just going to very briefly go over these two old definitions and then we'll go over the new definition. Originally, dry was called a disorder, not a disease. So in 2007, when it was called a disease, that was an effort to make it seem more significant and actually aid in the way that we bill and code things in the US and other places so that we could get paid for actually finding dry eye in our practices. Importantly, it was discussed that it had some symptoms and there were other elements that were involved in the definition, including osmolarity and inflammation in the 2007 definition. Which brings us now to today. So for those of you who aren't aware, the DEWS II report, which stands for Dry Eye Workshop, I know that's sort of weird. It's like, why is there an individual letter for shop? But okay. The DEWS original report, which is called the DEWS report, the DEWS II report was the 10-year anniversary of the first DEWS report from 2007. And basically in that period of time, a whole lot of research happened, too much to print out in a small document. This is a huge volume. It's like the Encyclopedia of Dry Eye. If you're interested in seeing any of it, you can go to the Tear Film and Ocular Surface Society's webpage. Even if you just type in TFOS DEWS II, you can download all of those articles for free on the website. In particular, there's also a summary document, which is about 10 to 18 pages long, is a comparison to all these other long documents, and that gives you a snippet overview if you want to get a little bit more in depth than just than this presentation, but you don't want to read the whole thing. All right, the new definition started out as a process by asking the membership of DEWS, which was about 50 to 75 individuals from across the world, if they liked the old definition. And unanimously, everyone said that they kind of wanted something new, but no one really knew what that was. So we started down a road on this committee, which is the Definition and Classification Committee, to come up with a new definition. And we wanted it to have a structure and be somewhat similar to the old definition, yet highlight or make a note of things that were areas in which we had learned something over the last 10 years. So it was called a disease as it was before, and we all recognize that it has many factors associated with it. So we maintain the terminology multifactorial disease. When you have a disease, it's of a certain tissue. So the tissue that's involved is the ocular surface, and that includes the ocular surface, the lids, the lashes, and all the associated glands that would create any of the fluids that are important on an ocular surface conditions, the tears, essentially. So it is a disease of the ocular surface, which is characterized by a loss of homeostasis of the tear film. That was probably the most critical terminology that we wanted to use because it recognizes there are a lot of things that can change the homeostasis of the tears. When any of those things changes the homeostasis of the tears, it can result in dry eye. So normalizing the tear film, returning it to homeostasis, is essentially the goal of treatment. But if you just talk about things that impact the tear film, you're only telling part of the picture or telling part of the story, because certainly if you don't talk about what's associated with it, then almost anything could be dry eye. Allergy could be dry eye. So we went a little further and talked about how symptoms were part of the condition. Now, symptoms have been there the whole time, and included in the word symptoms are also the visual symptoms that your patients will talk about. Maybe even difficulty in doing visual tasks or needing to blink to clear the eyes in order to help make eyes more comfortable or vision more clear. It's characterized by tear film instability, hyperosmolarity, ocular surface inflammation, ocular surface damage, and then a new term, neurosensory abnormalities. We're also rounding out the package that has all of the etiological links to each other that make dry eye. So in general, the definition isn't all that different from what it was before. Homeostasis was a key factor, and the neurosensory abnormalities was also a new addition. In the past, I think, with classification of dry eye, it could be called evaporative dry eye or aqueous deficient dry eye. And I think most clinicians would say you should identify if it's one or the other. And very, very rarely do they occur together. But if you're a clinician, you know that yes, they do occur together. They occur together all the time. You can have some element of evaporative dry eye as well as some element of aqueous deficient dry eye. It's not exactly one or exactly the other. So there's really not two categories. It's almost like you have two bookends, and truth lies somewhere in between. So you're going to have a little bit of one and maybe a lot more of the other, and determining which of those is the most predominant form or the biggest contributor to dry eye is where you should start first with management. The classification scheme then started with the patient. So we did it a little bit differently than the classification scheme that was in the previous report. So if you start out with the patient, this is intended to be a little bit of a decision tree. So there's the patient at the top, and you ask if they have, well, ultimately you want to end up with a dry eye diagnosis or not. And so if you're to do that, you start out by asking if they have symptoms or not. We're first going to focus on the side that is asymptomatic. So if you have no symptoms and you have no signs, then you have no disease and you require no treatment. Okay, no brainer. Now, what about if you have no symptoms, but you have some signs? And that happens from time to time. I think that happens most frequently when you have a patient who's come in for an evaluation for something else. For instance, they come in and they have cataracts. So they're complaining about how their vision is poor, and you determine that there's cataract. However, you also see some signs of ocular surface disease. They may not have been talking about that when they came into you. Maybe they have dry eye symptoms and you didn't quite dig that out in your case history, because their most important thing in their life at that point was their vision because of their cataracts. So in that instance, you would go ahead. It very well could be that they have some dry eye or precursor to dry eye, and you would want to manage them appropriately, certainly if they were going on to surgery of some kind. You also might have a patient who has who's asymptomatic again, but has some neurotrophic condition. So in that instance, they could turn into a dry eye diagnosis. Signs might indicate management of dry eye is required, even though they don't have symptoms. Now, these would be your very obvious cases of the cornea as a mess. I mean, you'd see symptoms or you'd see signs all over, and they may be saying, no, I think my eye's okay. I've had these sorts of patients tell me after we've initiated treatment and they've been on treatment for some time that I didn't realize that my eyes felt so bad until they started to get a little bit better. So that's kind of a type of patient that you can expect to find as well. Well, what about on the other side, the symptomatic patient? Well, certainly if you have a symptomatic patient and you find some signs, you say, phew, okay, they've got dry eye. You go on and ask some triaging questions. The triaging questions we'll go over in a minute. Those help you rule in or rule out other conditions. And then you look at risk factors and other things that they might be taking, like other medications, et cetera, and then you manage them appropriately. Now, what about if they are symptomatic but you find no signs? We've all had them. They're the complaining patients who come in and you look and you see not much. I mean, maybe a dot or two of staining, but nothing that you would say, well, this is obvious dry eye disease. So in those instances, you could say that that's a preclinical dry eye. You might watch them. You might ask them additional questions. Under the Canadian consensus, you might decide that they're an episodic dry eye. And they could eventually turn into dry eye as well. Now, what about those patients who have symptoms, no signs, but their symptoms way outweigh what you see on their ocular surface? That truly might be the neuropathic dry eye, where they have other systemic conditions that are giving them a pain syndrome that may or may not be related to dry eye. This is an area that we're learning a lot about, and we don't have a lot of guidance yet, but I suspect over the next 2 to 5 years, we're going to see quite a few studies which help us as clinicians determine how you identify these patients better and then how you treat them appropriately. You end up with your definition of dry eye. Now, at this point, you have to determine which is the predominant type of dry eye that you have. You can have aqueous deficient, seen in the blue, and you can have evaporative, seen in the yellow. And if you notice, there seems to be more yellow in this diagram than blue. It was felt that a true evaporative only dry eye could occur, and maybe that was somewhere in the ballpark of 30% of the time. A true aqueous deficient dry eye might be more rare, maybe in the ballpark of 5% of the time, but a mixed version where you have some elements of both, and that little colored arrow sign that goes yellow and mixes yellow and blue also shows that you can go from one to the other. You might start out with evaporative and move towards aqueous deficient over the course of your disease, or you might go the other way. So this is drawn this way to denote that truly it is a mixed condition, and that identifying which of those that's predominant is the approach that you should take to manage the homeostasis. I'm going to flip through these real quick and flip to the next page. So if you wanted to look at some tips with classification, ask. You're never going to get to understand truly what a patient thinks or feels unless you ask questions. Now, you might not ask those questions. You might have your staff ask those questions. You may use an intake form that you just verify when you're in the room with a patient. There are ways to make this a more rapid collection of data from your patient. Pre-surgical management matters. If they're not saying anything, it could be that they're not saying anything because something else matters to them more. Dry eye is still there in the background, and you can tease that out. Triaging questions help to differentiate, and we'll go through the triaging questions in a moment. And certainly prevention, if you think you have that episodic patient or someone who doesn't quite have dry eye yet that you're watching to see, watch them and talk to them about it so that if they do develop more signs or symptoms of dry eye, they aren't hearing it for the first time. All right, we're going to take a little bit of a step back just to kind of see where we're at and do another polling question. So what percentage of your patients present with dry eye? And this would be of all your patients that walk into your practice every day, all days. Do you think that it's 75 to 100%, or 50 to 75%, 25 to 50%, or a quarter of your patient population might have dry eye? And when I say present, I'm using that in the loosest of ways. You can interpret that however you want. Either they're obviously telling you, or you find it. However you feel, you want to answer the question. I wish I had a little bit of music to put back behind this so that you could hear some music while I wait, but let's see here. It looks like the bulk is somewhere between 25 to 75%. Half of you are in that bucket. Some of you 10% of you see a high volume of dry eye in your practices, or most all your patients have dry eye. That may mean that you specialize in that. And some of you maybe aren't seeing that. Now, maybe you have a very young population, or maybe you're not looking. So, or asking. So if you're in the lower end here, you might truly have a practice that just doesn't find these patients, and that's fine. But you also might need to look a little harder, ask a little more, or incorporate a strategy into your practice to get there. All right, we're going to move on here. Okay, to follow up on that, we're going to do another polling question real quick. For you, how important are symptoms in a dry eye diagnosis? Would you say then they're extremely important? You always make them a part every time you're working with a patient, and maybe you do that in a variety of different ways. You say they're important, but maybe not the key feature because you're feeling like it doesn't matter to me what they say, it matters what I see? Or do you really use the rule of the road of what you see is what they have? Which of those seems more true to you in clinical care with your dry eye patients when you're making a dry eye diagnosis? Go ahead and submit your answers. All right, and let's see what you say. So, as I would suspect, when a patient comes in to talk to you, it's very important to hear what they say. I use this moment usually to bring up a study that was done by Carolyn Begley and Barbara Caffrey a number of years back. And they asked patients in a clinical setting to describe the severity of their symptoms and how impactful they were on them. And then the doctor actually graded the dry eye. And at the end of the study, they found out that practitioners tended to underestimate the impact that the dry eye status had on the patient significantly. They always would say that it was, at least a severity grade less. So I think that we maybe downplay a little bit what our patients are telling us, or maybe we're just too busy scribing to hear them what they're really saying. So again, this shows that if you incorporate something into your practice that helps you do this easier and more efficiently, that's a good approach. All right, so we do a lot of things to get to a diagnosis of dry eye. We do staining, we do tear film breakup time. We used to use Roseband gown, we don't do that anymore. We use Lissamine green now so that we can, that is assuming that we can get Lissamine green, which some of you are probably experiencing the same problem that we are in the US, where we're unable to get even fluorescein strips some of these days. But both of course, vital dye staining is one of the critical things in terms of looking at the health of the eye. I would call it, though, the Goldilocks way. I mean, it is fairly simplistic. If you were to take a time and look a little harder, you can actually see staining without a dye. You can do it. It's not always preferred. It's not as easy, certainly, but you can tell if there is, turn up the mag, slim down your beam, and you can look to see if you see the little hazy bit that could be corneal staining. It's obviously much easier if there's a lot more to see. We also now are spending some time using things like the Meibomian gland evaluator or our finger just to assess the quality of the secretions that come from the Meibomian glands. And that's a key component in determining whether somebody has evaporative dry eye or not. We'll get to that in a moment. I like to remind everyone who sees dry eye patients that exactly once, not to follow up, but exactly once, you should make a measure of either the Schirmer or the phenol red thread test so that you can rule out Sjogren's. I know, and I've done studies to show that both of these tests are extremely unreliable, but they're very unreliable as you get to be more normal. They're actually quite reliable and repeatable when you get somebody who has very dry eye. If you have a low result, you tend to have a low result time after time after time. So if you do find a low result, you can feel fairly confident that you have a low result. If you have a high result, that doesn't necessarily mean that it isn't truly lower and you've stimulated reflex tearing. So low is low is low. And knowing that you have a patient that might have a deficiency in aqueous or producing aqueous is important. There are probably other tests, and I'm going to go over a few in a moment, that you might do routinely. You might do them to screen dry, and again, that may make you a more specialty dry eye practice, and that's fine if that's your Goldilocks sweet spot, but you can diagnose dry eye with fairly minimal, with really nothing more than you already have in practice. All right, I do want to get a sense if any of you use osmolarity, though. So go ahead and answer this quick poll and let me know whether or not you use osmolarity in practice. For most of your dry eye patients, you have it. We have actually two. Oh, we have the iPen. Yes, sorry about that. You in Canada have the option of using two choices or having two choices to measure osmolarity. So do you have an iPen and use it? Do you occasionally use it, or do you just never measure osmolarity? That means you either don't have the equipment to do it, or you have it and it's collecting dust. Go ahead and answer for me how you're feeling about osmolarity. Now, while you're answering that question, I just found out recently that there are only 5,000 units of the Tearlab. This is according to a press release that was just out within the last month. There are only 5,000 units out there in the world, even though there are 40 countries which currently have approval to use the Tearlab. All right, look at you guys. So you just probably don't have it. Those of you, let's see, you got a couple of people out there about equal that are using either the Tearlab or the iPen. We don't have the iPen available in the US. From what I hear, it is a bit easier to use than the Tearlab, but I've yet to have it in my hot little hand to try it out. But when I say that there are only 4,000 units that are available across the world, this is probably true even where you are, that some of you just really don't have it. Now, should you get it? I think that there is some element of importance to looking at osmolarity, but is it going to change your treatment design? Maybe, but maybe not. We'll talk about that in a moment. Okay. This is the diagnostic algorithm from DEWS-II, and in a moment we'll see how this differs from your Canadian consensus algorithm. I mentioned to you the triaging questions, and I hope you can see my mouse here as I'm circling that. Those are in red, and the questions are listed down below in very small print in white. And so, of course, this, I always kind of come back to this diagram, was poorly designed because it's really hard to read the white print on the red background, especially if you're projecting this as a slide. But you can see there are probably about 8 or so questions that talk about things related to dry eye that would help indicate that you have somebody who has some dry eye. Oop, don't want to do that. Who has dry eye, and you're asking questions about dry eye, discomfort, dry mouth. You're also ruling out things like infection, severe allergy, and you ask questions about contact lens wear and other general health conditions and medications. So these are intended to be a little bit of a risk factor profile, but we're using them or calling them triaging questions in terms of determining if you have risk for dry eye. If you suspect they have dry eye because of asking those questions, then you would ask a few more questions about certain medications and contact lens wear. So this is sort of a package deal in terms of a case history. If you then have an indication that you think that you have maybe some dry eye or a hint of dry eye questions, then the recommendation is that you should perform a symptom assessment using a survey. And the two that have been most published in the literature and have the best data are the DEQ-5 and the OSDI. If you don't know what those are, I'm happy to send you either of them. They're both brief instruments. The OSDI was developed in conjunction with when Restasis was first put on the market back in 2003, and it was used in the original studies. And since that time, it's been used in more clinical trials of dry eye all across the world. So it's probably the most popular. The DEQ-5 was a longer instrument that within the last 2 years is streamlined down to be 5 questions and validated. So if you get a score on that of greater than or equal to 6, or if you get a score on the OSDI of greater than or equal to 13, that indicates that you have some form of dry eye. And then you would go on to look at a sign. So there's your symptom, and then you're going to look for a sign. And the signs could be one of 3 that are being recommended that you perform. Now, if you don't have the test, osmolarity, like most of you probably don't, as we know from the last question, that would be something that you wouldn't consider. So you would look at a tear film breakup time or ocular surface staining. And if you put in some dye and you looked at for breakup time and it was less than 10 seconds, or if you found some staining and there's a recommendation about where you look for the staining, and one of those was positive, meaning abnormal, in addition to an abnormal symptom result, that then is a diagnosis for dry eye. So like I said, and Goldilocks says, you don't need a lot to do this. You can do it. So you've made a decision that your patient has dry eye. This can occur in the context of a regular eye exam, or this can occur if someone comes to you for a dry eye exam. Either way, and either of those have implications for how you oversee your practice and how you manage your staff. Not going to get into that today, but having, and there are lots of lectures that you can go to, and I can recommend you to some people who can give you some good advice there if you're not sure what to do next. Having said that, you've done a few simple things, you've come to a diagnosis of dry eye, and then you subtype the dry eye. So as you can see in the yellow part, that's to help you determine if you have evaporative dry eye on the top, and on the bottom part of what we call the funnel, you can see that is the aqueous deficient side. Now, the recommendation for aqueous deficiency is a measurement of tear meniscus height. Some of you may have access to an Oculus keratograph. It is an instrument that has a dry eye suite. It has a widget that you can actually measure the height of the prism, or you can do this a down and dirty way where you look at the width of the lid margin and slit lamp and make a guesstimate that that's about 1 millimeter, and you fraction the tear film in comparison to that and look at the height of the tear meniscus compared to the overall height of your width of your lid margin. Either way you do it, you can come up with a tear meniscus height measurement. Anything less than 0.2 is considered to be abnormal aqueous deficient. Likewise, if you start looking at the meibomian glands, express the glands and look to see if you see some signs of meibomian gland dysfunction, then that can be anywhere from mild to severe. So it's almost as though your patient is going to be a dot somewhere in between both of these categories. Maybe they're going to be more up towards the top, maybe they're going to be down towards the bottom, maybe they're going to have both elements of each. Either way, you look to see what you have when you're classifying the dry eye patient after you've come through the initial series of tests. How does that compare from what you've been told to do based on your own experts and expert opinion? I will say that this consensus algorithm was definitely considered by the group who wrote the one that I just told you. So certainly all the information that had come before fed into the decision of what the DEWS2 group produced. I really like the 4 questions. I think they're very, very good questions, and they come a little bit from Paul Karpecki, who I know helped with this. And we did something called the Dry Eye Summit a few years back, and these 4 questions were 4 questions that we came up with as being key questions that really resonated with practitioners, that they felt helped them identify dry eye patients. And so Paul incorporated them into the Canadian consensus with others and through discussion. But if your eyes feel uncomfortable, if you have watery eyes, if your vision fluctuates, or importantly, if you use eye drops. And I think that question is a really valuable question. If they've sought eye drops at the market or by themselves or from a friend or from you before, that is a high indicator that they likely are trying to solve a problem that they have. So if any of those are yes, you evaluate risk factors. That's very similar to what the DEWS process says. Then you do a screening examination, and then you would evaluate significant findings and schedule a patient for a complete dry eye workup. I view this as being very similar to the process that's listed in the diagram we just went through, where the screening examination is everything that's in that blue box in the middle, and the scheduled patient for a complete workup would be everything that you do to evaluate or subclassify the condition. You can use fancy tests or not, but again, you probably want to go into a bit more depth. So suggested order of dry eye disease workup is listed there adjacent to the little diagram with the arrows, and you can see that you would ask questions about case history, osmolarity if you have it, fecal red thread test, or Schirmer, and in the instance of the DEWS report, they suggested you could also use tear meniscus height, do some staining, meibomian gland expression, and anything else that you might want to do on the basis of what you own or how you want to approach dry eye as a specialty. Having done all that, then you come to the diagnosis either as episodic or chronic. We've had a lot of discussions lately about the word episodic and what that means. If it is, I think it truly is real, and the question is, when do you treat it? So in this management scheme, it's almost considered as an emerging dry eye, and maybe it feels to me a bit more, and how you practice might be different, but it feels a bit more to me like you're not really sure if it's there. Maybe it happens if a patient is on an airplane or they're in a condition which wind is blowing on them and they're irritated. That then translates further into having that occur more frequently, truly being episodic, that you can predict when that's going to happen on the basis of knowing that environment. And then you turn into chronic. Now, chronic doesn't mean that in my mind, chronic is when you actually know you have it and it is the condition. So we're splitting words a bit here. How the approach in terms of management goes is very similar between the two. You do it in a stepwise approach. So if your patient is telling you that they have some element of dry, you might be managing it with your more over-the-counter available things. And as you get more chronic, you might be using more of prescription medications. Having said that, I think that you can have somebody who has maybe episodic that you actually do give a prescription medication to. It depends how severe that might be for that patient. Also might depend on what their meibomian glands look like. So this is a general recommendation, and with recommendations, they're not all right and they're not all wrong. You have to figure out what works for you and how comfortable you feel treating at any stage. My note to you would be, as a public health person, I have a master's in public health, so I believe in prevention. And so if you can convince a patient that some sort of early management is better and get them on a course, they may likely not turn into that really bad dry patient that you don't want in your practice. You don't want that patient to drop out of contact lenses. So if you can try and get it earlier and treat it earlier, you may have a better long-term success. Having said that, it's nearly impossible sometimes to convince a patient into a treatment when they don't think anything is wrong, or it's not wrong enough to make a change or to commit to a therapy, especially if you're doing things like hot compresses or lid hygiene, which requires everyday activity. That can be a really tough approach. That's where some of this expensive equipment can come into play. And honestly, this is where osmolarity can come into play on occasion, because if you can show a change in the numbers, or a stabilization in the numbers, or a stabilization of their image, if you're showing them a picture of their meibomian glands, or if you're talking about changes in their tear meniscus height, all of this specialty equipment can be patient management positive in terms of helping you work with your patients and helping them understand their condition. From the Canadian treatment algorithm for chronic dry eye, the biggest difference that I see here is the recommendation for a steroid trial as the onset in the chronic dry eye as a trial. That's a little bit different than some of the approaches that are done in the US. It's not right, it's not wrong. It certainly is an option. You also see that there's a recommendation to consider omega fatty acid supplementation and ensure that lid disease is addressed should it be there. So I'm very curious how many of you actually have put that into practice and use a steroid trial. So go ahead and answer. If you do use this consensus and you do for chronic dry patients, those are no longer episodic. If you're using a steroid, how often do you do it? Is it 75 to 100% of the time, half the time-ish, less than half the time, but you do it, or kind of you just don't do it? So if you're at zero, you've never done it, you're never going to do it, go ahead and answer choice D. Again, in looking at this, there's been a lot of ways in which steroids have been used in the U.S. We have a different environment than you do in that everything that we do, we have to have a link to in order to get paid for it, in order for your patient to be able to use it, you have to you have to be able to compare to one another, and sometimes that can be difficult. All right, let's see. 43% of you don't do any of the trials, or maybe you've done it once or twice, but not routinely. And there's a good 16% of you who are really doing this. So I would say that those are you 16% are the believers. I mean, so you probably have a pretty high adoption of most dry eye principles and are following a pattern. If you can get yourself into a pattern, that is the best way in order to manage dry eye. And your pattern is probably not going to be the same pattern as somebody else's. That's okay. Today we're going to talk both about Restasis and lifitegrast. You don't know as much about lifitegrast, and you're going to have to choose, because for you, all things are sort of equal. You can pick one or the other. In the US, we have to jump through some hoops. Sometimes they'll let us use one and they won't let us use the other. Certain payment plans or insurance plans cover one and the other is not. So we have that element that's added on top and flavors the way we prescribe. If our patients can't get it, then they're never going to use it, of course. And so that does play a role in how we choose in the US to manage. Let's move on here. Okay, I want to know, before we go into anything further, how you use Restasis. So go ahead and answer how you use Restasis, and try and do it quick, because I'm going to go quickly through the next few slides. I'm giving you a couple seconds to address in this polling question Yep, there we go. How you use Restasis, if you use it all the time, some of the time, none of the time. Go ahead and answer that for me. Now it's been, available to you to use. Some of you, okay, so we've got a few that use Restasis, but we've got a lot of non-users here. So we have some opportunity to let you kind of know about a new choice. I'll say I use both in practice and have. I've been very involved with both companies, and in the U.S. both have a place with the kinds of patients and the coverage and certain insurance plans that we have. I know that there is less likely to be a very rapid change in symptoms with Restasis, but it does seem to, once you get to that point of 1 month or maybe sometimes a little bit longer, it can actually be very effective. If I have patients that are on Restasis and they're happy, I don't change them. I think I'm fairly consistent with most of those users out there who do the same thing. If you have happy Restasis patients, it's not really something that you're going to take them off a happy treatment. Now, sometimes I have Restasis patients, and I've talked to many other doctors. I haven't done this as much, and I'll be honest there, but I have talked to quite a few doctors who are doing both therapies concurrently. They have Restasis patients that are not all that happy, but they are hesitant to remove them from therapy to try them on a different therapy. So they're adding lifitegrast on top. I've heard many have good success that way. I have also heard doctors who use a high dose of omegas as their adjunct therapy, and some of those doctors are using up to 4 grams a day. Now, that can be irritating for a variety of reasons, but those doctors who get good compliance with, say, Restasis and an omega, and they're actively managing or watching their lids, can get a reduction in symptoms quite significantly. Having said that, we also have a new option to talk about today, and that fits into the stage 2 category. Again, the DEWS management is very similar to what you've seen previously. And we're gonna move towards understanding lifitegrast in a moment. Let me show you real quickly a few things. We know that in the tiers, there are lots of things. So over the next few years, all of these proteins that are in the tiers are going to be responsible for helping us to find new biomarkers and new therapies. So stay tuned. I think that the 2 that we have are certainly the tip of the iceberg, and we're going to continue to see more. I want to remind you that you need to also look at the bioload on the lids and lashes. And if you have a lot of crud, shall I say, or you have Demodex, you really do need to address that. And this is one of many options you have in terms of products in order to address the lids. Don't forget about looking at the lashes. And the meibomian glands. We've talked that the meibomian glands are related to making an adequate lipid layer, and you should have clean lipid coming out of those glands when you express. If you can see a blocked gland somewhere while you're just looking, you really don't need to express because you know what you're going to get. So there you can save some time there and not have to do the entire lid margin in order to assess every single gland. But do remember, and if you're not one of those people who's expressing glands, let me give you a little bit of advice. I use my finger. I have used a Q-tip, but I really do like using my finger. I've used that expressor from time to time. My finger works great. What you got to do is you got to put some pressure on, just kind of where you see that thumb in that image there. Give it some pressure, hold it, be patient and hold it. Remove your finger, move it next door, do the same thing, hold it, be patient, hold it, be patient. Now go back to your first spot and do it again, and you usually will see something. It's almost like you have to prime the pump, and you do use a little bit of sort of from the bottom up, a little bit of a roll when you're doing your pressure, and you can kind of get an idea that that's happening with the finger in the image that you see. A little bit of roll of pressure and hold it. Don't be afraid to just keep your finger there, almost for as long as I just talked. You really want to not give yourself a break and let you see what's really there. Also, if you're new to it, just try it on a normal patient first, and have it be a normal middle-aged person. Don't try it on your granny first, because her lid's going to roll in a way that maybe you're not going to get a good amount of lipid coming out, or maybe some of her glands just aren't making any anymore. So start with someone that you think you're going to get something, so that you can see what it's like, to give yourself some confidence. It's weird at first. I'm going to be honest. If you've not done it before, it's an odd process, but stick with it, and then you'll have a better idea of what's coming out of those glands and what their lipid looks like. You can buy lots of squeezers and expressors and have expensive equipment which will let you look at the meibomian glands. Meibography is a great tool, so consider it if you're thinking about starting a dry eye practice. Just a simple scrape of the lid margin can help improve, just get some of the crud off the lid margin. So if you've never had a spatula, or you've never tried to just do a very gentle scrape of the lid margin, that's usually a very effective way before you start doing an expression, if you want to try and do an expression as a therapeutic expression. Again, if you want some more information on any of these things, I'd be happy to answer some questions at the end, or you can contact me individually. This is an example of what meibography looks like in a patient who has had some loss, and you can see these are two images over some time. She doesn't have a great set of glands, but in the right-hand picture, maybe they look a little bit better. She'd been doing some treatment, and what we don't know is if that's glands that have come back to life. They're not supposed to, but are those glands that are, maybe less inflamed, easier to see? Are they making some lipid? Hard to say, but there does seem to be a little bit of a change of improvement there after she'd done Restasis treatment and had a LipiFlow. Her other eye, we used to say she's got a Texas-sized gland. This is when I was in Texas. One gland looks to be servicing the whole upper eyelid. She's asymptomatic. This patient really never complained about her eyes hurting, but when you looked at her lashes and her lids, they did look a little bit kind of thickened, like she'd had inflammation. You can see she doesn't have as many lashes as you would expect. I'm going to skip that polling question because I want to get to some things in a minute, and I don't want to run shy of time. Just remember to monitor your meibomian glands. Again, this isn't really about that, but I want to remind you there are a number of therapies, and in the U.S., intense pulse light therapy is becoming very popular in states where the practitioners can do it under their law. And so I think we'll continue to see some interesting information about IPL in the literature and in clinical care. You can see the pictures show some improvement over time, but it seems to be when you talk to the doctors who are doing it, they say it's very dramatic. We are wanting to help that lipid and make sure it's nice and clean and clear. There's a lot of stuff in there that we don't understand, and there's a lot of research going on to pick the right kinds of lipids that we might need to augment the tear film with. Any of the artificial tears that contain lipid don't contain any of the lipids that you see on this slide. They contain either man-made or other types of lipids that may help or might not help. So stay tuned in that area. Inflammation. So dry eye, any sort of stimulus to the ocular surface results in inflammation. It's how it works. It's what the body does. It responds to stimuli. And if you have stimuli coming from a dysfunctional tear film, from a tear film that has a high osmolarity or other systemic conditions that all feed into the cycle of inflammation, you get inflammation. Now, you can't see it necessarily clinically. It's not the obvious red eye. It's stuff that's happening on the ocular surface that can't really be identified. So I'm not going to throw this up there, but because I suspect that it's going to be a very low percentage of you who have used Inflamadry. It is a quick procedure that you can do. It looks like a pregnancy test. You can make a lot of fun jokes about that, but you take a tear sample and you get a result which tells you whether or not you've reached a high level of MMP9, which is an indicator of inflammation on the cornea that has to do with the inflammatory cascade. So you can use this in practice. We use it we're in a school of optometry, so we use it to teach students about the platform and what it does. We do it at our full dry eye examinations. We don't usually use it to monitor treatment. However, I do know practitioners who will use it in conjunction with, say, Restasis or Lifitegrast and omega fatty acid supplementation. They use it as a marker of whether or not they're getting their inflammation down and have had good success in the way that they use it. I can't say that I've adopted that in clinical care, but it is something in a platform that I think we're going to see more of in the future. Let's talk a little bit about Lifitegrast. Cyclosporin has been around for a bit longer. It uses T cell activation. The T cells are activated and then are some are activated and some are not activated on the ocular surface when you use cyclosporin. So the ones that were activated the second before you took that first drop are still going to be activated for up to 90 days. So they're there. It kind of, I've heard it talked about that lifitegrast it kind of closes the door where they can't get in, whereas the T cells, in terms of their being activated, that's sort of like, kind of stopping them where they start. So two very different approaches in terms of addressing sort of the same thing, the T cell on the ocular surface. And I think that because of the way of their mechanism of action being so different from one another is why I think lifitegrast might attract or stop symptoms at an earlier and maybe more robust way. Don't forget about the omega fatty acid supplementation. So what is Xiidra? Xiidra is a first-in-class molecule that was designed specifically for the purpose of dry eye and attacking this sort of interaction that occurs between LFA1, which is lymphocyte function activated antigen, and ICAM1, which is on the ocular surface. So at the bottom there you see in this little cute little schematic that ICAM is sticking up from the ocular surface. In dry eye, it is upregulated, so there's more of that sticking up from the ocular surface, and along comes the T cell. When it attaches to the ICAM through the LFA1, what that then allows is that T cell to come into the tissue into the tissue on the ocular surface. Otherwise, it would just be going down the bloodstream and keep going. So when I say this slams the door, what it does is it allows the T cell, or doesn't allow the T cell to get into the tissue. It kind of keeps it from getting in. It can be activated or not activated, doesn't matter. It's just not going to get in. And so that's essentially how that works on the ocular surface. Here's a picture of what it looks like. And again, it was a molecule that was designed specifically to be small, non-binding, get through the mucus to the tissue, have good bioavailability, and low systemic exposure, high solubility. So it was multiple iterations of the molecule were made so that it could be used for this purpose in dry eye. Again, what has happened is it blocks the interaction of ICAM and LFA1. And if you never remember that, just remember the door analogy. It doesn't allow the molecule in because it doesn't allow the binding between ICAM and LFA1 to occur. So then the T cell can't. You've heard it connects, it rolls, it goes through the tissue into the tissue. So it can't do its normal process because it can't bind. Now, that's what we know in a petri dish, in cell culture, in animal models. What's truly happening in the human, we can assume the same thing is happening, but we don't exactly know, and that's why they say the exact mechanism of action is unknown. Just like the exact mechanism of action of cyclosporin is unknown. We just can't know in the human. We can suspect what's happening through animal and cell culture models, but not really truly what's happening in the human. Knowing that it does bind to these particular antigens or not helps us understand the mechanism as we think it works in humans. So to briefly go over the studies of what's happened with lifitegrast, they've gone through the FDA process of having signs and symptoms evaluated in a number of FDA clinical trials. There have been 4 double-masked 12-week trials of Xiidra. That's the normal process in which you go through. Over 2,000 patients have been randomized to either Xiidra or placebo, and they look for improvements in signs and symptoms. The symptom was inferior corneal staining, or the sign was inferior corneal staining, and the symptom was kind of a comfort on a 0 to 100 scale, and I'll show you that in a minute. Eye dryness, essentially. Here's a summary from a recent publication in JAMA that reviewed all of the studies that had been done, and I put little red boxes around those that showed statistical significance at the different time points. Day 84 has always been the main time point for the studies and how they were designed, and so you can see the phase 2 study of 5%, and then Opus 1, Opus 2, and Opus 3 are the 3 phase 3 studies that were done. There was also a safety study called Sonata, which was a year-long study. So in each of these studies, you see that signs, symptoms were met in 3 of the 4 studies, and also signs were met in 3 of the 4 studies, but signs and symptoms weren't met always in every study. that's the FDA has said that signs and symptoms should be met in 2 studies and replicated in order for FDA approval. What Xiidra did and what Shire did is they went forward with this package of information and said in the course of these 4 studies, signs and symptoms were evaluated. In each case, 3 were significant, and really there were 2 studies in which they had signs and symptoms. The last study was designed solely to be a symptom study, although they evaluated signs and hit the signs as well. But at the point where they were submitting to the FDA, that was data that was just coming in, and that study wasn't it was powered so that they could find that statistical finding, but it was kind of the late entry. But given the burden of the evidence that they presented to the FDA agreed that it should be approved. One of the things that you do consider in a new drop, and what you've likely heard, is there are some adverse events associated with any eye drop. If you put water in somebody's eye and they have dry eye, some of the times they're going to say that it hurts. So we did see in that study, and we were a site of the study, and I've been part of the publications related to the adverse events, that installation site burning and irritation and installation site reaction were commonly reported by patients. And these are terms that are classifications based on it's called MEDRA. So it's a standardized notation way of capturing information from patients that are involved in studies. And you'll see these words used for all kinds of studies. When we talked about reduced visual acuity, that's like transient visual acuity, and most importantly what people say is that there's an altered taste sensation. We call that dysgeusia. In reality, when you talk about these burning and stinging, and when you talk about the dysgeusia, they do occur in patients. And in some instances, the sort of burning sensation that patients will feel, it's rare, but there have been some patients who really don't like that. It seems to be that patients talk about it differently than the kind of burning and stinging that Restasis patients experience. Restasis patients seem to really say that it is more of a stinging, and almost it seems like the irritation here in some patients can borderline on a weird ache. But they do describe them differently. The dysgeusia is sort of like when you give yourself nose spray and you have that sort of taste that you get from the nose spray, whether it be Afrin or any of the steroid nose sprays. If you've done that before, that's exactly what the taste is like. I've never had patients that have quit because of the taste, but some of them do experience the taste and report it. It usually isn't a reason for quitting, especially if they've achieved a symptomatic response within a short term. Now, I have had some patients who have had maybe some symptomatic improvement and they're still experiencing that taste and maybe the discomfort, and they're debating, whether or not they want to quit or not. That might be somebody that you want to translate over to Restasis and see if they respond any better to that. I haven't actually done that very often, but I know it's commonly done by doctors when they're trying to choose. That's assuming that both can be covered by our insurances in the United States. But having the discussion with your patient about any of these signs and symptoms, whether it be Restasis or Xiidra, should happen as you're giving it to them and take a little bit of time, because if you explain the taste sensation to them, they're not going to think it's weird. They may have it and they may go, oh, okay, it's kind of like a nose spray. So they do occur. It seems as though the stinging occurs with approximately the same frequency, or maybe a little bit less than what you experience in the body of Restasis users. But of course, the altered taste sensation is something that's a little bit unique to this molecule. If you want some additional information on lifitegrast, there have been a lot of papers that have been published. I'd say that Shire has been very upfront with their wanting to get the word out about Restasis, or I'm sorry, about lifitegrast from the very get-go. All the papers have been published from all the main trials, and there have been a number of other op-ed and other sources out there that you can look to see how it works and other information like that. We don't have any head-to-heads at this point comparing Restasis to lifitegrast. So with your inflammation management, it's all a risk-benefit, and in our instance in the U.S., a cost and coverage issue. For you, I say you need to be doing your own internal. You should try lifitegrast. It very well might be, and we're kind of going to just get to the cases, but your new dry eye patient, and I know we're over time, so I want to end this, but your new dry eye patient that's never had any prescription before, they would be probably a candidate I would really consider for lifitegrast, especially if they're symptomatic and you want to relieve their symptoms rather quickly. In as quick as up to 2 weeks, it would be worth trying. If you have a patient that's tried Restasis and quit for some reason, there are a lot of those out there. They maybe tried it but didn't give it a full try. You could either go back and try them on Restasis again and make sure they do it right, or you could try them on lifitegrast. If you have a dry eye patient that's taking Restasis and not getting full effect, you may want to consider adding both. If you have, or if you want to try and do a switch over, again, I caution you really need to be very careful with somebody who's successful on current treatment. How this would work with your steroid trial, it's hard to say. It may segue real nicely that if they respond in terms of symptoms, you might want to get them really quickly onto lifitegrast, or you could go straight to cyclosporin. Either way, you probably would start to see a response pretty quick in both cases, I would think. So really, it's going to be a matter of trying to sort through how you feel and what you try. Both medications have benefit. The quick response of lifitegrast does seem to be remarkable. There are some patients who never really get full symptomatic improvement, or their symptomatic improvement with Restasis occurs later than 1 month, even up to 3 months. And so it's worth considering which approach you might want to take. Importantly, and these slides are kind of all the same, it is very important to follow up. So how soon after should you follow up? What we do usually is to ensure that they've gotten the medication and they're okay with it. We kind of do a 6-week follow-up. When I talk to clinicians who've been doing dry for a lot longer, they may do a 3-month follow-up. They just don't want to see them back that frequently. And so it kind of depends on you. Certainly a 1-month prescription, they should last them 1 month. So if you see them at 6 weeks and they didn't refill, they might be 2 weeks into their no refill. So maybe you kind of want to encourage them in order to get that refill so that they continue on with therapy. Make them kind of commit to you to use their therapy for at least 3 to 6 months so that you can start to see any improvements and give them some good advice. Okay, it is important to note that if you have a contact lens wearer, you're supposed to put the drop in before you put the contact lenses in either scenario. You're supposed to wait some time, certainly before. So if they're going to be putting it in across the day or at the end of a day or towards the end of a day, or they wear their contact lenses a long time, you want to make sure that they're taking them out before they put that latter drop in the evening. If they do have problems with the burning and the stinging or the dysgeusia, you might want to encourage them not to do it immediately before bed, to do it and then give themselves a little bit of time before they close their eyes and go to bed. All right, so if you have patients headed for surgery, you may take a different approach. Certainly a pre-surgical patient that doesn't have or has episodic dry, you might want to put them on lifitegrast for the weeks up until their surgery, just so that they get a smooth and clean ocular surface. Patients with ocular allergy certainly also can benefit from both of these medications. If you need to talk about their workplace, or their workplace is a drying environment, or their computer monitor is in the wrong place, or they never take any breaks, it's worth having the discussion about preventative therapy, menopause patients, and screen time overload, which you all are right now, is certainly important in all of our lives and worth a discussion. Okay, so then I just need to leave you with time for a few questions. I know we've run over and I really apologize for that. We got started a little bit late waiting for some of the rest of you to show up and join the call. So if you have questions, please feel free to email me at any time. Try a trial in your office. Just make the commitment to do a little bit of dry eye and you'll be helping out your patients. It's not hard. I am confident that you can do it. So just keep calm and express. Thank you very much, and I think we're about ready to take some of your questions.
Thank you, Dr. Nichols, for this really insightful presentation. Just before we get